Ma'am, we should start, I guess.
Okay, sure. Good evening, everyone.
Good evening, ma'am. Good evening.
I'll first start with the remaining part of session 1. Okay, and I'll go really quickly. Please feel free to interrupt me. You can keep your videos or your audio on and you can ask questions anytime. If I'm missing any of your chats, please interrupt me anytime you want. Okay. So spillover from session 1, the things that we missed in session 1 from anatomy, physiology, and valvular heart disease perspective. We are going to study branches of aorta, some of the physiological laws of cardiology, MR, AS, AR, that is the remaining valvular heart disease, RHD, prosthetic heart valves, and infective endocarditis. So this is the aorta and its branches. It's a single slide. Why I wanted to show this kind of questions are often repeated especially in MRCP part 1. Some of the clinical questions of the part 2 might also come from these branches of aorta. So aorta can be divided into the root of the aorta, ascending aorta, aortic arch, and descending thoracic aorta. So the first branches, as we studied last time, are the coronary branches. When we come to the arch of the aorta, that is it is a left-sided arch. So the first branch is the brachiocephalic trunk on the right side, which divides into the right subclavian artery and right common carotid artery. From this subclavian artery, two important arteries goes up. One is the vertebral artery and one is the right internal thoracic artery. Both of these are of clinical importance. Any posterior circulation stroke may happen with vertebral artery occlusion, and this internal thoracic artery is or can be used for CABG or coronary artery bypass grafting surgery, though the left-sided artery is used more often. But RIMA, this is also called the internal mammary artery. RIMA or LIMA both can be used for bypass grafts. Okay. So the next branch of the arch of aorta is the left common carotid artery here. Then there is the here left subclavian artery. These common carotid arteries will go up and divide into internal carotid and external carotid artery. Always remember the internal one is the more important one, which supplies the brain and goes and forms the circle of Willis and gives the two major branches in the vein, anterior cerebral artery and the middle cerebral artery. Okay. So subclavian artery, again you see the vertebral artery and the internal thoracic artery or the IMA coming down. And these arteries supply the anterior intercostal arteries. As you remember, the intercostal arteries forms a chain in the neurovascular bundle in the inferior aspect of ribs. So this chain is formed anteriorly by the anterior intercostal arteries and posteriorly by the posterior intercostal arteries. The posterior intercostal arteries are branches of descending thoracic aorta. All these are very important for anastomosis in cases of any occlusion in any part of the aorta, which is commonly found in coarctation cases. Okay, this is the abdominal part. So the frontal branches, these are the single or median branches. The first one is the celiac trunk, which supplies most of the GI tract. It has three important arteries: left gastric, common hepatic, here splenic artery. So celiac trunk, then superior mesenteric artery, then inferior mesenteric artery. Three anteriorly facing single median arteries. Other arteries that supplies the organs are usually paired, like the right renal artery and the right gonadal artery. Okay, and this aorta goes and divides into two terminal branches: right internal iliac and right common iliac and left common iliac arteries, which again gets divided into internal branches and external branches. We have to know this anatomy very well for especially transfemoral cases like transfemoral TAVI and everything. Okay, these are renal artery, again a site of interventions for the cardiologist in cases of renal artery stenosis. So these are the arteries that are not drawn in this diagram: inferior phrenic artery, this and middle suprarenal arteries. These are again paired arteries. Middle inferior phrenic is the first paired artery that the aorta, descending aorta, releases after it pierces the diaphragm and comes down. And middle suprarenal arteries are just above the renal arteries. Then comes the lumbar arteries, which are 8 to 10 in number. which comes from the posterior aspects of the aorta and supplies the vertebral column. Median sacral artery is a single artery again, which comes from the posterior aspect of the aorta. And artery of Adam Kiewicz. Can anybody tell what does this last artery supply? It's okay. We'll move on. If somebody remembers, please type it in the text. So I'll come to the physical laws in cardiology. Afterload, we talk, this is the contractility and afterload relation. So we have to know, these are all from our first year MBBS contractility, how preload is related, how afterload is related. So what is afterload? Afterload is the pressure or the tension against which the heart muscle pumps. So it's mostly related to the arterial pressure or for aorta, it will be the systemic vascular resistance because it is pumping into the systemic circulation. For pulmonary arteries, it will be the pulmonary vascular resistance because it is pumping into the pulmonary circulation. So afterload for which one is higher? Obviously, for left ventricle, it is higher. So left ventricle is thicker, bigger, has more power generating capacity. Okay. And this is how, with increases in afterload, contractility keeps on decreasing in adult, but not so much. It drops very sharply in newborn and it drops very sharply in RV, that is right ventricle, which has less thinner muscular walls. So with rise in pressure, there is more chances of failing of a newborn heart or more chances of failing of a right ventricle, which is why if the aorta is occluded, you don't suddenly get a patient in left heart failure because LV is quite strong. But if the pulmonary artery is completely occluded, like in pulmonary embolism, then you get sudden right ventricular failure, which is called acute cor pulmonale. Next topic is the arterial pressure wave curve. These pictures can come. So in MRCP part 2, there will be many images and nobody can say what kind of images will come. There can be schematic images, laws, there can be ECG, echo, X-ray, anything, cardiac CT, cardiac MRI. Most of the images I will deal with in the last session, but always remember these images of the physical laws. This is right atrium, left atrium. Though both of these have 3 positive, these are the atrial waves, which are similar to the JVP waves, right? Everybody knows why A wave, C wave, and B wave happens. A wave due to atrial contraction. C wave corresponds to onset of systole with bulging of the tricuspid valve into the right atrium. This is the RA wave pattern. In LA, it will be bulging of the mitral valve into the LA, right? And V waves is the filling wave. When the blood fills into the atrium, corresponding atrium, they will have the V wave. You can see that in right atrium, the A wave is more prominent, and in the left atrium, the V wave is more prominent. Why is it so? If anybody knows, write it in the chat box. Otherwise, I'll tell after 5 minutes or so. Bernoulli principle. Bernoulli principle is actually very easy. Imagine a pipe. If a fluid, Bernoulli actually gives this theory about any fluid. It can be liquid or gaseous form. But here in blood, we apply it for liquid forms only because we are dealing with blood. So increase in the speed of a fluid occurs simultaneously with a decrease in pressure or potential energy. So this is a fundamental concept in fluid dynamics. And this is a complicated equation. From that, we somehow derive this P equal to 4V square. Somehow why? I'll tell you. One of this V is the velocity due to the action of gravity. But all these fluid principles that we talk about in cardiac hemodynamics, we consider the patient is lying down and all points of the body are experiencing same amount of gravity. So we ignore the gravity part and what we get is delta P equal to, that is change in pressure is equal to 4 into V square. V is the velocity at which the fluid is traversing an orifice or a canal. This is very important, especially for echo estimation of pressure differences between two chambers or pressure differences across any abnormal orifice like ASD, VSD, PDAs. Okay. Now coming to the next law, that is the Boyle's law. Boyle's law states that A1 into V, like volume of a gas increases, the pressure decreases. From that, we actually derive the continuity equation. Continuity equation is slightly different. It is the area into velocity is equal to area into velocity in the opposite side. If there is no loss in energy between two systems, the area into velocity product of two systems which are connected to each other through an orifice remains same. This is the principle with which we calculate the aortic valve area. Remember this continuity equation is used to calculate the aortic valve area in echo, because in echo we never can calculate it by plane planimetry. Which valve can we calculate the area by planimetry? That is the mitral valve. Okay.